This looks like a basic Crohn disease question, but identifying the disease is only step one. The real question is whether you understand what is driving the inflammation. A 23-year-old man presents with 6 months of crampy abdominal pain, nonbloody diarrhea, and a 7-kilogram weight loss. Colonoscopy shows aphthous ulcers and a cobblestone appearance and a terminal ileum, and proximal colon with areas of normal mucosa in between. Biopsy reveals transmural inflammation and noncaseating granulomas. Which additional finding most strongly supports the underlying pathophysiology of this patient's disease? A. PANCA positivity or PANCA positivity with an interleukin-13 dominant immune response causing continuous mucosa-limited colonic inflammation. B. Loss of immune tolerance to intestinal microbiota with interleukin-12 and interleukin-23 mediated T helper 1 and T helper 17 polarization. C. HLA-DQ2 restricted activation of gluten-reactive T cells with antibodies against tissue transglutaminase. Or D. Defective epithelial barrier function followed by IgE-mediated mast cell activation against dietary antigens. Choose your answer before we break it down. The correct answer is B. First, identify the disease, but don't stop there. The terminal ileum and proximal colon are affected, but normal bowel appears between the inflamed areas. Those are skip lesions. The inflammation is transmural, meaning it extends through the bowel wall. Add aphthous ulcers, cobblestoning, weight loss, and noncaseating granulomas, and this is classic Crohn disease. Now comes the actual test. Crohn disease is not simply inflammation caused by a pathogen, as you know. It results from a dysregulated immune response toward the intestinal microbiota in a genetically susceptible patient. The interleukin-12 pathway promotes T helper 1 differentiation, producing cytokines such as interferon gamma. The interleukin-23 pathway supports T helper 17 activity, producing inflammatory cytokines such as interleukin-17. Together with cytokines including TNF-alpha, these pathways sustain the chronic granulomatous transmural inflammation seen in Crohn disease. This is also why therapies targeting TNF-alpha, interleukin-12 or interleukin-23 can be effective in Crohn disease. Choice A is designed to pull you toward another inflammatory bowel disease. A typical T helper 2-like signaling, including IL-13 and PANCA or PANCA, are more strongly associated with ulcerative colitis, but ulcerative colitis causes continuous inflammation, beginning in the rectum, and the inflammation is generally limited to the mucosa and submucosa. That does not match skip lesions and transmural inflammation. Choice C describes celiac disease. Celiac disease is associated with HLA-DQ2 or HLA-DQ8, antibodies against tissue transglutaminase and T-cell-mediated injury triggered by gluten. Its classic biopsy findings are villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes, not transmural granulomatous inflammation. Choice D describes an allergic mechanism. IgE cross-linking causes mast cell degranulation and immediate hypersensitivity symptoms that can produce gastrointestinal symptoms after exposure to a food allergen, but it does not explain skip lesions, cobblestoning, or non-caseating granulomas. So, the answer is B. A dysregulated immune response to intestinal microbiota with interleukin-12 and interleukin-23 mediated T helper 1 and T helper 17 polarization. Now, here is a pattern to remember. Crohn disease goes deep, skips areas, forms granulomas, and favors T helper 1 and T helper 17 inflammation. If you recognize Crohn disease but missed the immune pathway, that was the trap, this question. All right, that was the question for today. See you next time.